I want to talk to you about a treatment modality without the side effects that you just heard. So no issue with dry ejaculation, urinary incontinence, bowel problem. So this could be maybe an important treatment modality for carefully selected patients. Let me go back here. These are summaries, so I'm going to talk about 5 points today, 10 minutes or so. So you see, you probably heard of this PROTECT trial, 15 years outcome. So if you have low or intermediate risk disease, no matter which modality you pick, active surveillance, surgery, radiation, you live about the same as your neighbor down the street who picked surveillance or surgery or radiation. Everyone had the same mortality. However, if you're on the active surveillance arm, you can see that you're twice as likely to get metastases and local progression. Now, treatment does come with these side effects. So is there a modality where we can decrease this risk of local progression and metastases and give you the same equal outcome in terms of mortality? So that's the goal. So here you can see the spectrum of disease. So for intermediate disease, most of the patient will pick surgery or radiation. And then some patient who has recent group grade 2, recent 7, may not be comfortable with active surveillance. They may pick surgery. So there's a modality where we just focus on treating the disease part of the prostate and spare the rest of the healthy tissue, and that's focal therapy. And at UCSF, we have offered three ways to do it. One is cryotherapy, high-intensity focused ultrasound, and irreversible electroporation. And focal therapy is also approved in the setting of relapse in terms of radiation recurrence. So in the past, the argument against focal therapy has been around the limitation in accurate staging, and we don't have a good way to predict how aggressive the cancer behaves. But now, over the last 10 years, improvement in terms of staging with PSMA, MRI, fusion biopsy, as well as genomic tests to predict the behavior of the cancer. So now more adopting focal therapy. So who are the candidate for it? So localized disease, intermediate risk, recent 7, 4-3 in some selected cases, and then a tumor in one area of the prostate. So you can see here, one area, you can have a quadrant or one side of the prostate, or if you have, we could do a hockey stick ablation if you have a contiguous tumor in 3/4 of the prostate. So the ablation, let me go over some of the consideration in picking the right patient. So most patients should have an MRI, fusion biopsy. We want accurate information about their cancer or the extent of the cancer before we offer this. And also determine what type of energy we use, and that's based on the location of the tumor. Posterior tumor, I tend to pick high-intensity focused ultrasound, that's done through the rectum. Anterior tumor, typically we pick cryotherapy or IRE. Tumor that is close to the urethra, we often pick IRE because we can ablate the urethra without cause damaging to it. And also we look at calcification of prostate. Ultrasound has limitation on that. So for calcification, we often offer IRE or cryotherapy. Brachytherapy seeds as another consideration that may interfere with sound, but may not interfere with freezing. So, so as I said, depends on the location, we pick the energy source. So at UCSF, we have, this is an example of high-intensity focused ultrasound. Using sound wave, you could focus the sound wave to 1 millimeter of tissue and heat that up to about 184 degrees Fahrenheit, and that turns into that kind of coagulate and destroy that tissue. And over time, that becomes fibrotic area and it shrinks down. So that's how you have to focus ultrasound. And then we have IRE, this is a patient undergoing IRE. Here, we insert this electrode around the tumor and deliver about 2,000 volt of electricity in that area, about 2 square centimeter tissue. And that basically breaks the cell apart and destroy it. So the guidelines. So focal therapy is not yet considered a standard of therapy in most guidelines. For the NCCN guideline, is only an option for radio recurrent cancer, not yet as a primary therapy. AUA guideline, expert opinion, clinician can select patient, well-selected patient can be offered focal therapy. European guideline said it should be done in a clinical trial setting. So what are some of the ways that focal therapy can fail? So imaging or staging is important. So inadequate margin. So here you have a tumor that is extending beyond the capsule. If you fail to recognize it and you offer focal therapy, you may miss treating that cancer at the margin. The other one is the biology of the cancer. Tumor that's well perfused, they may wash the heat away, and then you get decrease in heat. It may not be enough to destroy the tumor. Or you can have a synchronous tumor along that side or opposite side that was not detected on biopsy. The other one is the inadequate staging. A patient may have cancer elsewhere in the prostate that you don't know, that MRI or CT scan may not see. So I'm a big proponent of using PSMA PET early on, even in the low intermediate risk setting to look for these, what we offer them. So, and what's I want to talk to you here is our UCSF experience. What about the outcome? So in terms of side effects, we all know that it has minimal or no side effects. However, how does it perform? How does it perform? So here's our data on cryotherapy. Dr. Xian has been doing cryotherapy for many years. Here's about 95 patients. So failure-free survival, this is defined as needing a surgery or radiation. So at 2 years, 94% of patients did not need surgery or radiation for whole-gland treatment. And there is a slight decrease in their sexual function. Their urinary function remained unchanged before or after cryotherapy. And here's data on high-intensity focused ultrasound. This is the data of 135 patients who had Gleason 7, 3 plus 4, 77% of patients, 23% of patients had a grade group 3. And then in terms of CAPRA score, 44% has low CAPRA, 49% intermediate, and 7% high. All men get a biopsy at 12 months. So you can see here, 46% didn't have cancer or low-grade cancer. The other 41% had in-field recurrent, 13% had out-field recurrent. Now, if we look at, this is at 2 years after the ablation, 84% of the patients did not need whole-gland treatment, so they didn't need surgery or radiation. 16% needs surgery or radiation. So, but when we look at sexual function, no change. We looked at any complication higher than a grade 2 or so. We didn't see any of that. We didn't see any change in the urinary or bowel function. So in our data, we think that we show that the recent gray group had a high genomic risk predict for recurrence. So we're doing a lot of research on that. So the endpoint. So some of how do we follow these patients after ablation? PSA is not reliable. We know that. Our study and others have studied. So typically we track PSA, but it can fluctuate. So if the PSA goes down, we still do a biopsy to confirm that there's no cancer or there's cancer that needs to be treated. If there's 2 consecutive rise in PSA, then we typically do a biopsy sooner than 12 months to see if we have cancer outside the prostate that was missed, or the cancers that survive the ablation. And then imaging. So MRI right now is the gold standard to follow the patient after. We're doing a lot of research on hyperpolarized MRI. It may be better than the 3T MRI. And also PSMA PET, integrate that into the surveillance follow-up of this patient. So everyone gets 1 year systematic biopsy and also biopsy the area that may be visible on MRI or ultrasound or the other area that we played before. So what do we do after? So we have post-treatment here. So we have the cancer, we decrease the risk, then they continue on surveillance. If the risk remain the same, we often offer another round of ablation or surgery or radiation. If the risk goes higher, then we offer surgery or radiation. And the good thing about focal therapy is that when you pick surgery radiation, if you have a recurrent or the cancer didn't work with the focal therapy, you can get surgery or radiation. That shouldn't have much impact on the way we do surgery or radiation. So you don't burn any bridges, basically. So here's an example of a patient, a 69-year-old man with Gleason 3/4 that was diagnosed in 2019. He has, fully low risk based on genomic tests. So he went on to active surveillance, and 2 years after on active surveillance, his risk goes up to Gleason 4/3. His Decipher test also goes up. So we elected to do focal therapy, and we treat that area. You see there, the post HIFU biopsy downgrade his risk again back to just microfocus ultrasound. So this patient, we decrease the risk. We didn't cure his cancer, but we decrease his risk, and he still keep his sexual function, urinary function, bowel function, and change. So I was going over this with Dr. Carroll yesterday. He said focal therapy is intended to mitigate risk, and we're looking at that right now. How much risk we can reduce with this focal therapy. So we know that it's the data is solid on preserving sexual function, bowel function, urinary function of the focal therapy. And inferior recurrent, you can see his ranges. Ours is about 40%. I think this is high. We are doing many extensive research on how to improve that. And in summary, the effectiveness of focal therapy hinges on careful patient selection, monitoring the patient after, and also use all advanced imaging. So I'd like to conclude with acknowledge Dr. Carroll here. He's instrumental in giving me the task to lead a HIFU program a few years ago, and Dr. Kasuto Sinihara, who's been doing CRI for many, many years, way before me. Dr. Kasuto is instrumental in getting the HIFU machine to us and the rest of our team.